Good afternoon. I'm Jenny Bennison. I'm a GP at Niddrie Medical Practice in Edinburgh, and I've been a member of the guideline development group for this new eating disorders guideline. I've been working with colleagues Heather Ireland and Pam Thorne on this particular area, and grateful to everybody for their input. So what do we want to know? Are therapies effective in improving outcomes for eating disorders in children and young people? We'll be looking at antidepressants, antipsychotics and other drugs. Comparisons are made with other pharmacological therapies as well as with placebo and with usual care. So listed here are the outcomes we're interested in for this group. Symptomatic relief of distress and anxiety needs to be near the top of the list, clearly, and achieving remission and avoiding relapse are very important too. Adverse effects, including weight changes, are very important, especially in this group, and cost effectiveness has to come into the equation as well. Looking at anorexia nervosa in children and young people, there's a real lack of quality evidence for the use of antidepressants in people under the age of 16. Antidepressants didn't seem to have any impact on weight gain, and their impact on eating symptoms and psychopathology is not clear. One review concluded that early intervention was associated with improved outcomes. Research into the use of olanzapine is difficult in this group. Over 70% of individuals refuse to enroll in the studies, mostly due to fear of weight gain, and there are very high dropout rates. Follow-up periods tend to be quite short. Many patients who do take part in these trials are also involved in psychotherapies of various sorts and are often also taking antidepressants alongside. So it's very difficult to draw conclusions about the efficacy of any particular drug under study. Recommendations for anorexia nervosa then are as follows. Psychotropic medications, most often olanzapine or fluoxetine, are often prescribed for children and young people with eating disorders, usually in an attempt to mitigate specific behaviours like uncontrolled exercise or another comorbid condition. When medication is prescribed, it must be monitored very closely, particularly given the altered physiology and low body weight in many of these patients. Baseline ECGs and routine blood testing is important. When weight has been restored, standard guidance can be followed for the treatment of obsessional symptoms, anxiety disorders and depression, as well as other conditions. Where psychotropic medications are prescribed for young people with anorexia, consideration needs to be given to audit and research with patient consent around these treatments, as well as careful monitoring. Moving on to bulimia nervosa in children and young people, there is a real lack, again, of robust evidence. However, this shouldn't preclude the use of medication where there are comorbid conditions like anxiety disorders, OCD, and depression. Fluoxetine at a dose of 60 milligrams daily may be considered in the treatment of patients aged between 16 and 18 in combination with psychological therapy and with careful monitoring. Suicidal, self-harming or aggressive behaviours can be seen, particularly at initiation of therapy. Remember that fluoxetine is only actually licensed in those under 18 for the treatment of major depression, so use in younger patients with bulimia is unlicensed. For binge eating disorder, there isn't any specific evidence for pharmacological therapies in children and young people, and in adults it's clear that psychological therapies are the most effective treatment. There's been a lot of publications around this dexamphetamine or LDX. This is an amphetamine which has been shown to reduce binge and purge behaviours and to reduce BMI in people with binge eating disorder. However, dropout rates are high and adverse effects are very common: gastrointestinal upset, sleep disorder, nervous system arousal and headache, to name but a few. And there are major concerns around the long-term use of this dexamphetamine. So recommendations for binge eating disorder are that pharmacological therapy should not be used in the management of children and adolescents with binge eating disorder. Thank you.